Good morning and welcome. This is 10 Years Hence. Our focus this morning moves from the topic of global governance to COVID 19, global pandemics, and the future of healthcare. Dr. Bernard Nahlen is director of the Eck Institute for Global Health. His career has been spent working to address the many diseases that disproportionately affect people in low and middle income countries. From 2007 to 2017, he served as deputy coordinator of the U.S. President's Malaria Initiative. When launched in 2005, the goal of the PMI was to reduce malaria related mortality by 50% across 15 high burden countries in Africa through rapid scale up of proven tools for malaria prevention, diagnosis, and treatment. During his time as technical lead, the initiative expanded to 24 high burden countries in Africa, as well as to Cambodia, Myanmar, and Thailand. He developed partnerships with the ministries of health, multilaterals such as the World Health Organization, UNICEF, UNDP, the World Bank, and the Global Fund. He worked with other bilateral aid agencies in the UK and Australia, private foundations such as the Bill and Melinda Gates Foundation and Clinton Health Access Initiative, as well as non governmental organizations and the private sector. In 2015, WHO reported that malaria deaths had declined by 60% globally since the year 2000. A graduate of the University of Notre Dame and the University of Arkansas for Medical Sciences, he completed his residency in family practice at the University of California, San Francisco. As well, he had a second residency in preventive medicines at the Centers for Disease Control and Prevention. In 1992, he served in Kenya, where he spent 7 years as director of the CDC Field Research Station in collaboration with the Kenya Medical Research Institute. Ladies and gentlemen, please help me welcome to the stage of Jordan Auditorium a Notre Dame graduate and a pioneer in global healthcare research, Dr. Bernard Nahlen.
Thank you, and thanks for the opportunity to be here in this wonderful setting among the survivors of the present pandemic. I thought it would be worthwhile when I was asked to speak in this series to talk a little bit about pandemics, what's happened in the past, where are we now, and what's likely to happen going forward. So I'm going to talk a little bit of brief history of pandemics, some of the emergence of global health governance mechanisms that try to keep us all safer, the challenge and limitations of some of these mechanisms, how prepared are we for the next pandemic and what's the likelihood there'll be one, and last but not least, lessons from the present COVID pandemic. I'm a big believer in looking back on what happened in the past. Obviously, 10 years from now, someone will be looking back at this period on the COVID thing to see what that taught us and how we can learn from that going forward. Obviously, one of the earliest pandemics, which I'm sure you're probably familiar with, was plague in the 14th century, which killed about 25 million people, which is about a third of the population of Europe at that point in time. Plague, of course, is a bacterial disease that's transmitted by fleas that feed on rats, and it results in, they call it bubonic plague because it results in these skin lesions and pulmonary lesions, which result in a very high likelihood of dying. This is an illustration from the 14th century of plague victims. So what would you do? This was a time when people didn't understand infectious diseases. There weren't, the whole germ theory was not even around back then. People thought that when you get sick, it's because of bad air. In fact, since I spent a lot of my career working in malaria, the word malaria comes from the Italian for malaria, bad air. So what would you do at that point in time? What could you try to do to protect, if you were the Doge in Venice back then? And of course, Venice was a huge maritime power. with all these ships coming in from different parts of the world. And obviously that was also an entry point for plague into the European continent. So again, there were no vaccines, antibiotics, this or that. So the city officials in Venice decided to institute the first quarantine laws, where ships arriving were asked to not land yet in the port. They had to stay off port for 40 days before they were allowed then to come into the port and unload. So the term 40 days in Italian is 40 giorni, which is where the word quarantine comes from. How many of you were in quarantine during COVID? Yeah, a lot of you. Well, it's good it wasn't for 40 days back then. It was only for 14 days or 10 days. There's nothing magical about 40 days. It's actually not based on any particular scientific data, but it actually was very important during that pertinent time in the Bible and in Christian beliefs. If you think of, when the flood, it rained for 40 days and 40 nights. Christ went into the desert for 40 days. And so this whole number of 40 was associated with trials and tribulations. And so that's where the magic number 40 came from, and the term quarantine. So this was the main intervention at that point in time. And then Venice went even further. They designated 2 islands in the channel of Venice. One of them was Lazzaretto Vecchio, where people who had symptoms of plague were taken off and put on the island and treated. And the other one was Lazzaretto Nuovo, which is the picture here, which you can actually go visit if you go to Venice these days, where people who came from areas where plague was a problem were taken off ships and kept on shore for 40 days in case they developed signs and symptoms of Venice. Again, these were obviously non-pharmaceutical, non-vaccine related interventions, because that didn't exist. So this is what they were doing to try to control that. This is a picture of what the doctors wore back then, because the belief was this long mask kept the doctor from having to get too close to the patient and inhale whatever, and this long garb and a stick where you could examine the patient. So if any of you are looking for your next Mardi Gras or Halloween costume, you can actually still buy these masks in Venice today. So again, huge early pandemic, huge devastation on human health, and they were doing their best using their thinking and the tools they had available at that point in time. Another major pandemic was cholera, particularly during the 19th century. And again, this is actually a map. I don't know, see if I can, these red lines, let me see. There it is, these red lines here. This is a map of Amadeo Brigham in 1831, where he basically did this map looking at cholera routes from Southeast Asia, all the way, these trading routes, all the way through Europe, and eventually into the United States, even into the Great Lakes Basin and Chicago. There were 7 major cholera pandemics during the 19th century, which killed millions of people. And as I mentioned, it even arrived here in the United States in Chicago. Are any of you from Chicago? Yeah, a couple of you are from Chicago. Do you know anything about the history of the Chicago River? Could you say what the history is? Exactly. It's one of the great engineering feats of the late 19th, early 20th century, because...
Bernard, can you repeat the answer?
Oh, yes. The answer was they changed the flow of the Chicago River through a series of channels and canals. And the reason for that was, Chicago was, had this explosion in growth because of all the international trade. People were people, factories, they were dumping everything into the Chicago River, human waste, animal waste, chemicals that was flowing. The Chicago River ran into Lake Michigan. So the Chicago River would go to Lake Michigan, and where did they get their drinking water? They would suck the drinking water from Lake Michigan. So Chicago was not a very healthy place to live back then. And again, this is before antibiotics, but a brilliant thing that was done, a huge engineering feat. They dug these channels, a canal next to the Chicago River with some locks, and totally changed the course of the Chicago River to the point that today Lake Michigan runs into the Chicago River, and that then goes all the way down to Kankakee, Illinois, and into the Mississippi. I mentioned Kankakee because there's a famous Supreme Court suit. Kankakee was complaining that all the stuff from Chicago is now coming to Kankakee, but they didn't win that because it was pointed out, well, you're dumping all your stuff in the Mississippi River and it's going to farther down, so you don't have any place to complain. But to this day, you know, Chicago, the river runs from Lake Michigan into the Chicago River. So that was the intervention to allow Chicago to develop into what we know it is today. But the other thing that was going on back then, again, was the early emergence of global health governance mechanisms. You know, from 1851 to 1899, there were this whole series of these early international sanitary conferences because they realized, you know, you can imagine that map. People now start realizing that just having quarantine or isolation is not going to do the job when you have this explosion of trade. I mean, for example, shipping went from like 700,000 tons in 1850 to over 26 million tons by 1910. So this huge explosion. So particularly the European countries and the United States decided to start having these meetings to try to work together to limit the spread of disease. Initially it was cholera, but later it also included typhus and yellow fever and some of these other, the plague, obviously, and some of these other infectious diseases. In 1902, the Pan American Health Organization was established. The Pan American Health Organization is now one of the regional offices of the World Health Organization, and the headquarters is in Washington, D.C. But there were these other efforts, the International Sanitary Bureau, the Organisation Internationale d'Origine Publique in France, and then some of these other private sector players and foundations like the Rockefeller Foundation. After World War II, the League of Nations actually established a League of Nations health organization, but as you're probably aware, the United States never joined the League of Nations, so we were never part of that particular effort, and that sort of fell by the wayside until World War II. I point out the Epidemic Commission in 1920 at the end of World War I, because there's a huge outbreak of typhus in what's now Russia and Poland, and real concerns about typhus spreading into the other parts of Europe. It was the first time that rather than just advising countries what they should be doing, they actually sent out medical teams with soap and other tools to try to control the spread of typhus in that area. So it's the first time, rather than just talking about and giving recommendations, the higher income countries actually got together and tried to do an intervention at a local level. And of course, with World War II and the devastation afterwards, the United Nations was established, with the US being a huge mover of that establishment. And in 1948, the World Health Organization charter came into force. The World Health Organization continues to be the only, even though there's lots of organizations and agencies working in the global health space, the World Health Organization is the only agency that has the mandate from all 194 nations of the members of the United Nations to actually play the main coordinating and functional role in the world health space. I'm going to come back to this because of obviously some of the challenges with the World Health Organization. The flu epidemic of 1918, 1919, which was up until what we're seeing now, the major respiratory-borne pathogen causing huge devastation throughout the world. It has this misnomer, the Spanish flu. It didn't actually start in Spain. But over the course of, it happened very rapidly. The first few cases were reported in 1918. Here in the United States, they were first seen in US soldiers who were then being deployed to Europe during World War I. But by the time it was over, about 500 million people, or a third of the world's population, had been infected. Here in the United States, there were an estimated 675,000 deaths at a time when the population of the United States was much smaller than it is now. And worldwide, there were at least 50 million people killed. This was a virus, H1N1 influenza, which it took 15 years after the epidemic ended or the pandemic ended to know what the causative agent was. It killed 10 to 20% of those infected. And as opposed to the present virus we're dealing with, it actually killed people. One of the highest mortalities was in people 20 to 40 years of age. So huge, not only huge impact on human mortality, but you can imagine killing off people in some of their most productive years. So this 10 to 20% case fatality rate, whereas a normal flu season, which we see every year, the usual case fatality rate is about 0.1%. Well, again, what could you do back then? Again, there weren't antivirals, there weren't antibiotics, there weren't this and that. So what did they do? Any ideas? It's something you're all familiar with. And as you can see, the woman on the far left isn't wearing her mask properly. But yeah, a lot of places actually had laws requiring masks. Wear a mask or go to jail. I love this one. These are guys in San Francisco getting their haircuts outside in open air with the barbers being masked. Here's troops in Seattle marching in the streets who are all masked. And then shutting down public settings. Church windows must stay open. Police raid saloons, which happened even here in South Bend. I love this, open-faced sneezers to be arrested. So again, using the same sorts of interventions that were used early on here in COVID, which is, closing down public spaces, limiting contact between people, encouraging people to wear masks. That's all they had back then. The thing you don't want to do, and again, even back then, you had charlatans. Here you got Vino's lightning cough cure, which was, I guess if you have the Spanish flu, it'll save you. So again, even back then you had people marketing untried treatments in the midst of devastation. I put HIV/AIDS up here because when I was your age and a young doctor, I was in the midst of all of this. And it's hard to believe now, because now when you mention HIV/AIDS, it doesn't have the same sort of, it's still of concern, obviously. But if you'd roll it back when I was the age of many of you, the word HIV/AIDS caused a lot of fear, fright, contagion. I see people who were around back then nodding their heads. A lot that was not known about it, even concerns that might be spread by lice and mosquitoes and fleas and all sorts of other things. Some of the people early on who were most affected were some of the most stigmatized members of society. When I was early in my CDC career, I was assigned to Los Angeles during the peak of the AIDS epidemic. And frankly, it was frustrating, to say the least, because as a physician, and I know many of you probably had similar situations in your own families, this wasn't a disease that killed you suddenly. You got to know people. You got to know their life stories. You got to see them on a regular basis. And you saw, because we only had a couple of drugs which weren't working, you gradually saw them all die, and you helped them die. And it really was only when I first left the US and went to Kenya, this revolution in treatment for HIV, to the point that, and again, if you look at this was the point I'm talking about, where AIDS was essentially a death sentence for the majority of people, to the point that today, again, deaths in the United States they're not zero, but they're markedly lower than they were before. And that's also true globally. I mean, there's been an estimated 36 million people who've died from HIV/AIDS globally, but there's another 37 million people living with HIV because they're on treatment, and there's about 1.5 million new cases every year. So again, one of the revolutions in science was to have better treatment, better diagnostics, laws in place so that people who are, parts of society that aren't that well accepted are being protected. People aren't going to lose their job. They're able to get health insurance, et cetera, et cetera. And that's changed the whole trajectory of HIV/AIDS. Well, where are we now? And again, you've all lived through this. And one of these days you'll be an old codger like me looking back. Yeah, when I was here. Well, COVID-19, and as you know, there's a lot of controversy, about where it originated. There's the Wuhan Institute of Virology, the concern that there may have been a lab leak of some sort. This is in the Wuhan area of China, and there's like a lot of collaborations between this laboratory and scientists here in the United States and globally. They were working with coronaviruses. I should say there's no evidence that there was any sort of bioterrorism. Nobody did this purposefully. No one manufactured this, but there still is reason to believe that there may have been a lab leak. Of course, the other is here in the same area of China in Wuhan, these live animal markets where animals are being brought in, butchered. You can buy it fresh. That's typical in many parts of China and other countries. And it's a setup for exposure to animal secretions and stuff and potential spillover into the human population. Well, here's where we are today. These are the WHO figures as of this week. About over 761 million confirmed cases globally, and almost 7 million deaths, although WHO agrees that's probably a gross underestimate. It's probably more in the range of 15 million deaths. And even here in our own country, the good news is you all have access to home testing for COVID now. So if you test at home when you have COVID, that's not going to be reported. So even in our own country, we've lost the ability to actually say how many cases are actually still out there. But the good news is that the number of deaths is actually trailing off. And that gives some indication that we're probably at a point in time where there's a certain level of herd immunity, both because of vaccines, but also because of infection and a combination of those. So what's the future of COVID? Well, there's the worst case scenario is we get a new variant that is even more infectious than the Omicron variant and even more disastrous on human health, like the Delta variant. Those two are combined, so you end up with something much worse.
Bernard, I see a spike around January 1st in confirmed cases that's much larger than any other indication. What accounted for that?
Well, part of that had to do with China opening up. If you look at what China did, China did something amazing, not something you could do in most countries, and it's not something most of us want to have to go through, where they locked people down in their apartments. And even like to go to a store, you had to have a special permission. You probably read about this. It was like, it was just only China could do this. And you probably saw that then there were protests about this because people were getting fed up. And those protests, China had this zero COVID policy. We are not going to allow any transmission. We're going to actually be able to have no COVID, which frankly, was pie in the sky, to say the least. I mean, there were a few places where that might have been possible, like New Zealand, which is an island. But once China opened up, and even now the cases reported from China are probably gross underestimates, and the deaths reported from China are gross underestimates. But part of that is this opening up of China and this huge population. I mentioned the vaccine because frankly, again, as a scientist, this is one of the most amazing advances in science and I've ever seen in my career. Because if you look at some other diseases, for example, whooping cough, the disease organism that causes whooping cough was first identified back in 1906. It was not until 1948 there was a vaccine for it. That's like over 40 years later, and not until 1988 that over half the world's population had been vaccinated. Polio, when I was growing up, people were afraid of polio. Well, the agent was first identified back in 1908, but it's only in 1955 there was actually a vaccine for it. And of course, now we're almost on the verge of polio eradication, which would be the second major disease in the world eradicated after smallpox. Measles, the causative agent, was discovered in 1953. And again, these diseases had been around for much longer than that, but to actually discover the causative agent, measles, in 1953, well, fairly quickly, a decade later, we had a vaccine. You look at COVID, it's amazing, with the first reports from China, within a month, the Chinese scientists published the genome. There was already work on mRNA vaccines for coronaviruses. So the companies were able to, and scientists were able to take that, put it on this platform. I remember in the midst of 2020, when they started the phase 3 trials, I was thinking, well, if we have a vaccine that's like 50% efficacious, that's good. Given the devastation of this, we should go with that. When the data came out that it's like 95% efficacious and the safety profile was incredible, I was like shocked. But again, you look how quickly this happened. So it's within less than a year, we had not just one, we had 3 different vaccines with a high level of efficacy. And we recognize that just having a vaccine doesn't mean you can roll it out and people are going to accept it, et cetera, et cetera, et cetera. But that has saved, the estimates are the vaccine here in the United States has probably saved 1.5 million lives just because of that one tool we had in place. Oops. So I go back to, well, where'd it come from? Well, just last week, some of the Chinese scientists published, they had collected swabs and stuff from the Wuhan market, when these different animals coming in, and genetic samples from the market were uploaded into an international database, which then scientists around the world were able to look at. And it appeared to be this one particular, it's called the raccoon dog. It's actually a canine. They call it a raccoon because of the way it looks. And these were animals that were being, brought in live and slaughtered in the market itself. So this, at least at the moment, the genetic information would suggest that this may be the intermediate host that caused the jump into the humans and exposure. But as soon as, again, we can talk about why is China doing what it's doing. As soon as this data went up and people were able to see it, the Chinese then downloaded it. So the Chinese scientists are trying to play ball with the rest of us, but for whatever reason, the Chinese government took that data off the website. So you can no longer, well, now you can because people copied it. Most pandemics are of zoonotic origin, which means that they're spillover from animals to humans. And about 2/3 of the emerging diseases all have an animal origin. So zoonotic diseases, there's different ways humans are exposed to zoonotic diseases, and we're all exposed on a almost an ongoing basis in different ways. There's direct contact through secretions from infected animals, either petting or touching or bites or scratches, or in the case of live markets like in Wuhan, it's a different level of exposure. Indirect contact, where animals live and roam around, like aquarium tank, water, pet habitats, chicken coops, barns, plants, soil, pet food, water dishes. Vector-borne, we don't normally think of vectors as animals, but they are. So being bitten by a tick, an insect, or like a mosquito or a flea, which almost all of us are at some point in time during the year. Foodborne, there's about 1 in 6 Americans every year who eat contaminated food. And waterborne, drinking or coming in contact with water that's been contaminated with feces from an infected animal. I'm just curious, does anyone know what the most dangerous animal in the world is? Mosquitoes, right. There you go. I have a little slide here in a second. I'll give you some numbers on that. We don't normally think of that. Humans are the second most dangerous. Mosquitoes are the first most dangerous. And of course, animals can transmit all sorts of different agents to humans. Fungi, bacteria, these are just examples. Parasites, again, I spent a lot of my career in malaria, and that's a parasitic infection that was spilled over from great apes through mosquitoes to humans. Other viruses, in addition to COVID, you're familiar with, Ebola. The most recent one, of course, you're hearing about is monkeypox, although that's now been relabeled by WHO as Mpox because it was giving monkeys a bad name. It's not actually, it looks like it's more of a rodent virus rather than a monkey virus. So all these different agents of infections, we can have spillovers from animals to humans. And again, even though we're all concerned about lions and tigers and bears and sharks and stuff, mosquitoes and humans are the most dangerous animals on the planet. And again, mosquitoes, it's not just malaria. I mean, when I first came to Notre Dame, it was sort of like a tail end of the Zika pandemic, and I mean, you've all lived through that. Now nobody's talking about Zika, but there will be something else going forward that will be a vector-borne disease. And of course, Lyme disease is spreading. You probably all heard of the frog story, that frogs won't come around boiling water. But if you take a frog and put it in a pot of water and slowly heat it up, the frog doesn't realize that it's being heated up, and eventually, well, as the water comes to boil, the frog will die. Well, frankly, that's not the way frogs act, but this is the sort of myth out there that if you put a frog in water and slowly heat it up, well, frankly, in my view, we humans are like the frog in the water and what's going on now when it comes to climate change. You know, we're in a situation now where the world is heating up around us. A lot of us are kind of don't seem to be too concerned about that. And you all heard eventually there'll be this tip over point, which will be the equivalent of boiling. We're already seeing some of these signs now. And I expect that in my lifetime that remains, I'll continue to see more of that. Certainly, you younger folks will be dealing with this going forward. I bring up climate change because, again, it's a huge factor when it comes to the likelihood of having future pandemics. I mean, warmer temperatures increase the range of disease-carrying insects. You know, we're already seeing this here in, I mean, for example, Lyme disease. You know, the range has been expanding and continues to expand. You know, even here in this area, some of the viral infections that mosquitoes carry are bigger risks than they were in the past. Climate change can cause large displacement of populations. We're going to be seeing a lot of people on the move because they need to be, because they're no longer able to live and survive where they are. And once people start moving around, diseases in one population which may not cause a lot of problems because they have some background level of immunity are now brought into new areas where new populations are existing. An example of that you're probably familiar with is smallpox during the colonization of the New World, which came from Europe and devastated Native American populations here in this hemisphere. And the same thing can happen with other pathogens that will be moving around. Air pollution can catalyze the emergence of new infectious diseases and influence their spread, reduce ability. Exposure to unsafe water. Again, if you see these pictures now of flooding, well, you can imagine when there's floods, you're also getting all sorts of contamination from farms and contaminated bodies of water into human drinking water. As the infectious diseases may migrate to areas that were previously too cold for them to survive, and even something like malaria, there are, if it's too cold, malaria above certain altitudes, even in equatorial Africa, you're not going to see transmission. But as those areas become warmer, you're going to start seeing, and we are starting to see transmission at these higher levels. And then an interesting thing, which is worth paying attention to, is the melting of permafrost or glaciers could potentially lead to the release of pathogens into the environments. And again, this freezing of these parts of the planet goes back thousands and thousands and thousands and millions of years. And we're only now starting to get some sense that there may be some pathogens, which at the moment are not of concern to humans, but may end up becoming in the future. So what is the future likelihood of a COVID-19 level epidemic? Well, there's lots of people modeling this, and one of the most recent models took some of these data into account. There's about 1.7 million as yet undiscovered viruses in birds and mammals. 40% of these have the potential to spill over into humans. And this one model looked at the global population, air travel networks, because again, the speed at which humans can move around the globe now, and with humans moving around quickly the globe, then the pathogens can move around with them. How people move around at a more local level in communities, the country preparedness levels, and how people might respond to another pandemic. So they took all of these things into account in their model, and they came up with these figures that the probability of another COVID-19 level pandemic is about 2.5 to 3.3% per year. So on the one hand, maybe that doesn't seem like that much, but again, the average human lifespan is 75 years. I don't have that much left in me, and I don't have that much gas in my tank, but many of you do. So over a 75-year period, it's like in the range of 88 to 92% that there's likely to be another COVID-19 level pandemic, because we're always seeing little outbreaks and disease outbreaks and this and that, and smaller pandemics like the mpox. But when it comes to COVID-19, and it could happen as soon as next year or 10 years from now, or we might get lucky and go another 100 years like happened with the 1917-18 epidemic. I suspect we're not going to be that lucky. So it's highly likely, well, it's almost inevitable that during your lifetime you will be dealing with similar sorts of pandemics as we're dealing with presently. Larry Brilliant, who's actually a brilliant epidemiologist and physician, I love this, outbreaks are inevitable, but pandemics are optional. In other words, disease transmission at a smaller level among humans, that's going to continue to happen. But when it comes to a pandemic, there are things we can do to make that not happen. So allowing pandemics, not jumping on disease outbreaks early on to try to prevent them, that's optional. I don't know how well you can see this. The Global Pandemic Monitoring Board is a group convened by the World Health Organization and by the World Bank to basically they have this scorecard on, well, okay, if we had a new outbreak of a disease with pandemic potential somewhere in the world today, how prepared would we be? Can we be confident that every new country has the capacity to detect and control it? No. Can we be confident that crucial information will be shared rapidly and transparently? No. Can we be confident that healthcare workers will have the resources and protections needed for their work? No. Can we be confident that personal protective equipment, diagnostics, therapeutics, and vaccines will be channeled first to those in need rather than those who can afford to pay? No. Can we be confident that all nations will act promptly, effectively, and in concert to stop its further spread? No. Can we expect a different outcome for the next global health crisis? No. That's where we are now. And again, you have to remain an optimist to be involved in this bill. So I remain optimistic that we can change this scorecard and really figure out what we should be doing now to prepare for the next pandemic. So I'll just go through some things that are going on at present. Again, I point to the role of the World Health Organization. Happy to answer any question. I was actually at WHO for 5 years. Needless to say, it's not perfect. It is important. There's a number of reasons why it's not able to do the job that everybody expects it to do, but it is the main organization that has the convening power to bring groups together to discuss these global disease outbreaks. An example, I mentioned smallpox as the first disease to be eradicated. The United States and Russia worked together hand in hand on smallpox eradication throughout the Cold War. So disease and actually the Surgeon General at the time that WHO was launched, the U.S. Surgeon General in 1948, talked about WHO being actually an instrument for peace. And I believe that because even in my previous work in Washington, no matter what your political views are, you should be able to come together around these major human health threats. WHO, under their constitution, actually has some power for laws, from hard law to soft law. The hard law is the framework, is conventions. Those are the equivalent of treaties. There's only been one treaty in WHO's history that they've used that power, and that's the Framework Convention on Tobacco Control from the early 2000s. Obviously the US is a big player in that, and now in most countries, you can't, they're not handing out cigarettes to teenagers. They're not, in Paris, they're not smoking inside any longer. There's all sorts of countries that approved this treaty have all agreed to work together to diminish and mitigate the damage to tobacco. But that's the only time in WHO's history there's actually been a treaty. Most of this is more on the softer law, where WHO comes out with recommendations, which is sort of at the end of this. The other one I wanted to point out is the second level, which are the regulations, and particularly the international health regulations. And these were, the last time they were updated was in 2005. The international health regulations, and again, this is where the 194 members of WHO have agreed to prevent, control, and respond to risk of international disease spread in ways that are commensurate with public health risk and which avoid unnecessary interference with international traffic and trade. This is an important piece, requires all member states to notify WHO of all events that may constitute a public health emergency of international concern. So everyone has bought into these. Again, it's not perfect, and there's some criticism of why this isn't working as well as we would like to see. Why does it take so long for an outbreak to be identified? Here's an example of, in the COVID, this is the International Health Regulations Emergency Committee on the Novel. This is one of their first meetings where they were trying to decide, well, how important is this? So this is, again, a function of global governance that WHO has to bring together people to try to enforce these regulations. And of course, one of the challenges is WHO doesn't really have any ability to enforce this. They don't have like a place for it. You can't like force China or France or the US or anyone else to do something if they don't want to do it. I put this up there because potentially the second treaty in WHO's history could be this pandemic treaty, which they're proposing. It's recognized that the international health regulations weren't strong enough to prevent the catastrophic failure of COVID-19. So this new treaty proposes that international property should be waived during a pandemic. And those of you involved in the business sector, you understand what a huge deal that would be for companies and others to agree to give up their international property rights to whether it be a vaccine or needed drug or a diagnostic tool. and to allow poorer countries to manufacture vaccines and treatments as they become available. WHO would reserve 20% of all tests, vaccines, and treatments to distribute to poorer countries. Prices and contracts should be made public. And then this idea of differentiated responsibilities so that all nations have a role to play, but obviously wealthier nations have bigger obligations than poorer nations. And then the focus on provision of universal health care, so we actually work together to improve health systems in all countries. This is the treaty. We'll see. This is the first sort of iteration out there. We'll see how fast this goes. And again, I just point out that one of the challenges always is, even if this treaty does go through and the US and others sign on to it, it's really the goodwill of the countries themselves to implement this, because WHO has no ability to do so. One final point I want to make is that pandemics are expensive. Just in the year 2020, it was estimated that COVID-19 reduced the GDP globally by 4.5%. And in an estimated $89 trillion global GDP, that was equivalent to almost $4 trillion lost, not only because of the health impact, the economic impact, the social impact. I don't need to tell you about this because you've all lived it. You've seen it yourselves on the devastation that a pandemic like COVID could have, not only on people's health, but also on economies. So, again, I'm not a business person, but I do know the concept of return on investment. It's estimated that, the cost to prevent pandemics over the next 5 years is about $150 billion. Whereas if you just look at the cost of the COVID over 5 years, the estimated cost of that is $13.8 trillion. So in my mind, this seems like a good buy, but I know I'm prejudiced here. And how do you get people then to agree to do it? Who would come up with this money? Well, there's donor countries. The US continues to be one of the most generous and one of the main funders of global health initiatives. International financing institutions like the World Bank, some of these regional organizations like the regional development banks, private sector and foundations, and domestic resources, getting countries to put more of their own money into it. In fact, this pandemic treaty is asking for countries to put a minimum of 5% of each country, their national budget into pandemic preparedness. So when it comes to foundations and stuff,
given all that we've been through, it may seem surprising that I'm optimistic that we can prevent the next pandemic. Here are the 3 areas where we have to invest. First, we need to make and deliver much better tools. Diagnostics are very important, drugs that help you avoid getting seriously sick or dying. And finally, enough vaccines for the entire world within 6 months of identifying the threat. Second, we need this global team. I call it the germ team, the Global Epidemic Response and Mobilization Team. Stopping pandemics is what they're all about. Finally, we need to invest in health systems. A lot of these health systems in the poor countries are not very strong today. If we invest in them, we can improve the health in those countries every year, but we can also make sure they're capable of doing the disease surveillance. We need to be able to see outbreaks at their earliest stage. If we do these things now, we'll have a world that's prepared and can prevent pandemics.
So I bring up Bill Gates because, again, he's someone who is the Bill Melinda Gates Foundation is very involved in this space. Bill actually has a new book out, How to Prevent the Next Pandemic. Someone with his background, his wealth, his influence, I think is a major player at all sorts of different levels to try to get people really, and in fact, if you go back to a TED Talk back in 2015 he actually predicted the COVID pandemic that we're involved in now. But he's also involved in trying to get people to wake up and what should we be doing now to prevent the next pandemic. Last couple of slides several things happening this year, just FYI. One is that the UN General Assembly, which meets every September, will have a high-level meeting on pandemic prevention, preparedness, and response. And of course, you can always say, well, that's another UN meeting, so what? Well, it's important when it comes to getting every country leader in the world sitting down and paying attention to this. And how that plays out, it'll play out different in different countries, but it is an important step. I mentioned the negotiations towards adoption of a WHO pandemic agreement, hopefully by next year. The pandemic fund was launched by the World Bank, and the first round of funding is going to be this year. And again, this pandemic fund is primarily to help countries improve their ability to detect, their sort of first line of health workers and others to be able to report what's going on, laboratory diagnostics, be able to identify this, and also reporting systems. So you have the development banks involved in this space. I mentioned the international health regulations. There's some proposed amendments to those for adoption in 2024. At the country level, countries and other stakeholders are in the process of developing proposals for governance and financing of an equitable countermeasures platform. And like I said, part of that is putting more of their own national budget into this. The G7 countries are driving what they call the 100 Days Mission. And what that's meant by that, again, I continue to find it hard to wrap my head around how within 1 year we had highly effective vaccines. We now have some drugs that can prevent up to 60% of deaths in those at highest risk. We have great diagnostics, which you can access through your local pharmacy or mailbox. That happens so fast. But the point here with the G7 countries, of course, are the US and the other major economies around the world. This 100 Days mission is like, okay, next time this happens, we actually want to have interventions diagnostic within 100 days. And that's going to be involved in developing more investment into science, into the sorts of things which allowed us in a short period of time to make the gains we had when COVID hit. The G20 countries, which include some of the middle income countries, and have established a task force to strengthen collaboration between finance and health ministries, because frankly, in most countries, the weakest person at the cabinet meeting are the health minister. It's actually the finance minister who makes decisions about the national budgets. And then this whole idea of how you get people to play well together, this idea of having a universal health and preparedness review as a peer review mechanism to strengthen accountability and preparedness. So if country X says they're going to do this, but they're not doing it, again, you can't force it, but you can politely, as friends, say, well, you're falling behind. Why is that? So these are some things going on just this year, which those interested, I think, are worth paying attention to. And last, so what are the lessons we should learn from this pandemic going forward? Because there will be another one, sooner rather than later. One is to build resilient health systems. Even in our own country, that's an ongoing challenge. And there's large parts of the United States where, people don't have easy access to healthcare workers, clinics, hospitals, and even in major urban populations, there are populations within our own country, even when there are lots of doctors and nurses who don't have the same access to healthcare. And you can imagine what that then looks like in places like Kenya, where I live. So making sure that we have resilient health systems. Leadership and public trust are crucial. And frankly, I remain concerned about people's willingness to believe whatever they may be trending on whatever social media platform they happen to like. I'd like to hear your ideas on what you can actually do with that. I still think science is not perfect by any means, but I personally am frustrated when I hear a politician say, well, I'm not a scientist, but okay, well, I'm not an engineer, so don't ask me how to do this either. But at least there needs to be some consensus that we need to do the best we can to look at the facts and how facts become truth, and hopefully to have leaders then building public trust based on that, because in the absence of that, it will continue to be a downhill trend towards a free-for-all. We need to defend the integrity of science and public health agencies. You know, Dr. Bob Einterst here in South Bend, who's an incredible physician, leader, a lot of experience in global health, came to South Bend from IU to be the local health officer. But during the last elections, for a number of different reasons, today is his last day as a St. Joe County public health officer because of some really negative politics going on as a result of the last elections, people being attacked, and you've seen it. I mean, I know Tony Fauci. The fact that he has to have protection around him as a scientist, I just find mind-boggling in this day and age. We have to do better than that. Focus on equity. Again, making sure that I go back to the days of HIV/AIDS, where the perception was so long as it's just affecting these folks, we don't need to be too concerned about it. So these folks, we can just let them die because it's not going to be a threat to the rest of us. And of course, it was a threat to the rest of us. And frankly, from a moral perspective, that wasn't the right attitude to begin with. And we've seen this the same with the COVID epidemic, where even, again, here locally or throughout the country, communities of color were some of those most at risk. They were, and there were lots of different reasons for that. They were the essential workers. I mean, it's hard to believe now. You're seen as an essential worker because you're the one who needs to be in Martin's so people can go get their food. You're the truck driver. We normally think of essential workers as, you know, the doctors and nurses and the firemen and policemen. But a lot of these folks, they kept things going. They were the essential workers. They also, unfortunately, those communities don't have as good access to healthcare in many settings. They live in more crowded conditions. And, there's lots of different reasons. They take public transport. They don't all have cars. So we do need to, whatever happens next, make sure that that equity lens is there so that everyone who's affected, not just those who can pay, or those like me, who I could, you know, comfortably stay home. We need to make sure that we're all in this together. And I'm going to go back to this issue of adopting evidence-based laws and to safeguard the rule of law. And last but not least, we've already referred to this, to fund and support robust global institutions. WHO, I mentioned part of the challenge with WHO, which has this mandate globally. The budget of WHO is a third of what the annual budget for CDC is here in the United States. They're grossly unfunded. So this whole idea of having a cadre of global health, as Bill Gates pointed out, people to respond to global health way. Well, the money's got to come from somewhere. And up to this point in time, support for these global agencies has not been going up. Oops, I'm sorry, I'm about to go. So thank you.
So we have a few minutes to take questions, ask whatever you like. He assures you'll have a response, but it may or may not be the one you expected. This is, in many ways, uncharted territory. What's on your minds? Let me return to the issue of Tony Fauci. CBS 60 Minutes ran a piece last Sunday, about a 12-minute piece, about Dr. Fauci and his wife living with every day the equivalent of Secret Service security accompanying them everywhere they go, if they go for a run or if they go to the grocery store. How did we get to the position where evidence-based science leading to public policy suddenly became political, and the notion that politics ought to trump whatever the evidence says? You and I have been around long enough to watch what's happened. First, why do you think that happened? And secondly, what's the next step? What do we do about that?
You all probably have better answers than I do to this, because I continue to be shocked and can't wrap my head around it. I mean, and I just go back to someone like Tony Fauci, who, again, on my earlier career in HIV/AIDS, and those of you who were around during that period of time, Tony Fauci changed the whole course of the way we think about engaging the public in science. Because back in those days, things had to go through the NIH processes and FDA and this and that, and yet people were dying and they weren't getting access to a potential new drug, et cetera, et cetera. And there was a group called ACT UP, you probably are familiar with, the AIDS Coalition to Unleash Power. They would go to NIH and lock themselves to Tony Fauci's desk and all this other stuff. But here you got this government young scientist, back then a young, but he listened. And he ended up, well, yeah, they got a point here. This is a death sentence. And we're sitting here doing your usual government bureaucracy and making sure that everything. So he changed the whole way that NIH thought not only about their science and development process when it comes to some of these major issues, but also how you engage people actually affected by these diseases in those discussions. So some of the people who were back then, of course, back then some of these groups were calling for literally, in fact, I remember this one postcard I saw once with Tony Fauci and a target, a bullet on his head. Well, back in those days, of course, politics was not at a sense where you had to really be concerned that someone would take that truth, but these were people affected by the diseases saying he needs to be done away with. He listened, he became, and it's a famous story in the world of the HIV, but Tony Fauci is now one of the heroes in the fight against HIV/AIDS. Ebola, I mentioned Ebola. There's a vaccine for Ebola now. That's because of NIH and Tony Fauci leading the mRNA vaccines. The fact that now we have, frankly, politicians who are seeing someone like Tony Fauci as having a political agenda, or maybe even being dishonest or corrupt, and calling him out as someone who should be fired, who should be this and that, who should be jailed. It's just the level of our politics at this point in time, which is shocking. And frankly, at a very local level, during the COVID epidemic, there's a lot of public health leaders in counties and others who just resigned. We don't need to do this when you have people coming and accusing them of this or that, shouting at them, threatening them. They just resigned. So how, as a country, we get to a better place, I think all of you hopefully will be a part of helping to make that happen. I mentioned the recent change here in the South Bend, the county council. We now have a county council that thinks that the only job of a public health department is to do restaurant inspections and make sure the water is clean. The good thing is that at the state level here in Indiana, the governor called a commission, which has recommended, Indiana has one of the lowest investments in public health of any state in the country, $275 million to improve public health in Indiana. People on the county council here are going to Indianapolis to argue against that. They don't want any new money in public health. So I don't know what their game plan is, but what's going to happen, because again, it's not, will there be another COVID-19? It's just a matter of time.
Bernard, two questions that I sort of related. First, are we going to get another COVID shot, a booster this year? What can we expect?
That's a great question. I think particularly those who have particular health risk, who may have poor immune systems, the question continues to come up, well, should they get a second bivalent booster? Because those of you who've been through the original and you've had your one bivalent, do you need another bivalent? There's some reason to suspect that that may not be as necessary for most of us at this point in time, but there may be some folks, either because of age or because of underlying health conditions, where you might want to just err on the benefit side, that they might get additional benefit from having additional COVID bivalent. The real question comes up, well, what's going to happen with this virus? Does it just become, there are 4 coronaviruses, which is what COVID is, that cause a common cold. I mean, they've always been around here, but that's obviously this virus doesn't cause the common cold. But will it come to a point where it's now the 5th one that just causes a common cold? Or will it be more like the flu virus, where you get different variants and you see these seasonal peaks? So there might be a new vaccine targeted each year for what's circulating at that point in time. I think we're beyond, I really don't think that the worst case scenario is we're going to have a variant that is even more infectious and more pathogenic than what we've already been through. But there's no recommendation yet that everybody get a second bivalent, but I personally, as a physician, if I had a patient who has particular risk and they wanted to, I would say, sure, go for it.
It strikes me that during the pandemic in 21, 22, well, part of 20 as well, that the response for dispensing public treatment actually worked pretty well, involving commercial drugstores, CVS and Walgreens, as dispensers of inoculation. And if rapid testing proved that you are positive, to provide Paxlovid or something else on the spot. That struck me as very innovative, and for the most part, from my personal experience, seemed to work. What's your reaction to that?
Oh, absolutely. Again, those of you who are a little long on the tooth like I am, 20 years ago, if you wanted a flu shot, you had to go make an appointment with your doctor, go get and then coverage rates for flu vaccine was very low because it's just so the more you can do to make it easy. So the fact that you can now go to the pharmacy locally or in Walmart to get your flu vaccine, you can even get shingles vaccine. And now certainly once we had enough experience with the COVID vaccines to make that up where people can easily access that, makes perfect sense. That sort of task shifting away from bricks and mortar clinics and hospitals to bricks and mortar pharmacies and other access points.
Yeah. Questions? Anything on your mind at the moment? Yes, we have a question right here.
Hey, doctor, how you doing? I'm going to follow up on the previous question about advances. So often wars or pandemics advance medicine. Certainly in the pandemic, one of the things that was advanced was telehealth, and the good outcomes that we've seen from that. Do you see other advances that are coming out of the pandemic, whether structural, CVS, Walgreens, or within the practice of medicine itself, that the pandemic pushed us 5 or 10 years ahead?
Yeah, again, I think there's some really good things that are happening coming. And some of the trends were kind of already there, but now it's accelerated that. And some of you've seen in your own. The fact that you now realize not everybody needs to be in office every day. They can be on Zoom calls. And so even that was kind of there. The pandemic just accelerated that in a point that, same way if you look at training of clinicians, some of the technology we have now, for example, when I was in my medical school, we had cadavers. You learned gross anatomy, dissecting cadavers. You don't need that any longer. There's technology now to the virtual technology that's been developed for training around health issues is pretty remarkable. I think AI is going to be a whole game changer, which we're only on the verge of now, but we're starting to see where some of that can come into play. And even some of the issues of being able to identify there's a problem and what it's likely to be, and then what we need to do. I think AI is going to play a role in that. Other issues in lower income countries, when I lived in Kenya for many years, and those villages, if I wanted to have a meeting in the village, I would tell a driver, because you couldn't call out there. There was no, I want to have a meeting. And somehow through word of mouth, it would always happen. You show up and there's people. And now you go to those same villages, mobile technology is everywhere. And that's created all sorts of possibilities. You can imagine a village level. If in the village they see people or something's going on, they can report that. Someone has a phone, they can report that. If you're even managing diseases, you could send a message to patient X out in the village to reminding them to either take their medication or to show up. That didn't exist before. And there are things which I don't know what they are yet, but I will be surprised if 10 years from now we won't be looking back and this will be like the days of the dinosaurs, that there's be all sorts of exciting things going on which will change the way we're able to see and do things.
Thank you. Other questions? I don't see a hand. Here's one I know you follow. And this is among the least consequential things we've talked about today, but the process of discovery now has a much better documentation rate. People write things down, they capture the numbers, and then we talk about who gets credit. Is there a Nobel Prize for messenger RNA?
Well, if I were on the Nobel Committee, yes, I would give it sooner rather than later, because
Who do you think gets that?
Oh yeah, no, I mean, it's already been recognized with something. There's other prizes that kind of one level below the Nobel Prize. It's already been recognized, and frankly, big proponent, getting more and more women involved in science, because some of the pioneers in all this were all women. But the mRNA vaccine, not only when it comes to infectious diseases, provides a platform which we've now seen with COVID and what that can do, but there also there's work on diseases to prevent cancers and other sorts of health issues, which the mRNA platform provides opportunities now in research to actually start looking at some of this. And today we're talking about mRNA vaccines. There's all sorts of other stuff going on, which I don't know what they are yet, but that's why I'm a big believer in investing in basic science and seeing what comes out of that.
Ladies and gentlemen, Dr. Bernard Nahlen. So for your walk across the quad, we have a small gift. No TSA inspection required. Thank you so much for joining us, and thank you for all of your good work on behalf of mankind.
Okay, thanks. Thanks, all.
Thanks, everyone.